Welcome back to the deep dive. Today, we are taking a massive shortcut right into the future of surgery.
hmm
Our mission is to filter through all the noise and really deliver the core insights from the most significant and most viewed open access surgical research published in 2025.
Yeah.
This deep dive is designed to give you a comprehensive understanding of what is truly changing practice. Not next year, but right now.
And we're dealing with such a rich body of work here. It's not just, a collection of new gadgets.
No.
It's a snapshot of the entire surgical ecosystem. We're seeing major advances in visualization, some critical new standards for quality and safety.
And some head-to-head trials that just completely shatter long-held assumptions.
Exactly.
Before we jump in, we do need to acknowledge the source for this incredible analysis. The insights in this segment are based on the Sharp Review by Dr. Reza Lankarani, who is a general surgeon, founder of the Surgical Pioneering newsletter and podcast series, and an editorial board member for the Genesis Journal of Surgery and Medicine.
It's a fantastic compilation. He really brings together these diverse perspectives, which is exactly what surgeons need today.
Okay, so let's unpack this. We've organized these findings into 4 key themes that really tell the story of modern surgical advancement. We're starting with the theme of extreme precision, how new tools are making the invisible visible, and really changing diagnostic pathways.
Precision is, it's the holy grail of modern surgery, isn't it? For years, surgeons have relied on, tactile feel and visual cues.
Right, just experience.
Exactly. But things like small nerves can be so easily confused with fat or blood vessels. And our first stop addresses this head-on with visualization.
Right.
We're talking about the phase I trial introducing Reza.
Rise-Dispen. So this is a novel myelin-binding fluorophore.
Yeah.
To put that a bit more simply for you, it's an injectable dye that binds specifically to the myelin sheath. That's the fatty layer protecting nerves, and it causes the nerves to literally light up under a special camera.
It's incredible.
And this trial looked at using it during robotic prostatectomy, which is just the perfect use case. Nerve sparing there determines everything for quality of life.
And what's fascinating is the technical finding. The trial found the optimal dose was a pretty modest 3.0 millikilogram.
Okay.
But crucially, this dose produced sustained fluorescence of critical structures, like the obturator nerve.
For how long?
For hours. And with an excellent safety profile.
So sustained has to be the key word there, right? If it fades quickly, it's useless in a 4 or 5 hour complex robotic case.
Absolutely. The fact that it gives you visibility for hours with low toxicity means it's clinically viable. The editorial commentary praised this as a pioneering step in operative imaging.
I can see why.
If this gets adopted widely, it has tremendous potential to reduce inadvertent nerve injury across so many specialties, not just urology. It moves nerve identification from a guessing game to, a certainty.
So that's precision during the cut, but what about precision in choosing when to cut in the first place? This takes us to a really revolutionary melanoma screening breakthrough.
Right, the Merlin 001 study, this was a very large prospective study. We're talking 1,761 patients.
Wow.
And it validated a clinical pathologic gene expression profiling test, the CpG-EP test, designed to stratify melanoma patients based on their risk of having a positive sentinel lymph node.
Now, for you, the listener, this is huge. In melanoma, finding a positive lymph node, that dictates your entire treatment pathway.
Everything.
But getting that info means a sentinel node biopsy, a whole other surgery with risks, costs, and a lot of anxiety.
And what the CpG-EP test does is it measures the activity level of certain genes linked to metastasis right there in the initial tumor sample. And the results were just stunning.
How so?
The test reliably identified a low-risk group of patients who had under a 10% chance of nodal metastasis. It achieved an impressive 96% negative predictive value.
96%. Think about the emotional and physical cost of a surgery, the recovery, the worry all just to confirm your low risk.
Yeah.
Being able to identify 96% of those low-risk patients, we could potentially spare a huge number of people that biopsy entirely.
It's a massive shift. The biggest change isn't in the operating room, it's in the waiting room. Eliminating unnecessary surgery and focusing our resources only on those at a demonstrably higher risk.
Okay, so we've talked about maximizing individual precision. But what happens when the very technology we adopt for better surgery, what happens when it introduces unseen complexity? That's what the next set of findings addresses as we move into standardization and quality control.
And this is where we really need to challenge our intuition that, newer tech automatically equals safer outcomes.
Right.
A large international cohort study of over 2,700 patients did exactly that with robotic platforms.
You're referring to the finding that robot-assisted abdominal surgery, or RAS, was linked to a higher incidence of postoperative pulmonary complications compared to conventional laparoscopic surgery.
Yes, higher. It goes directly against the popular assumption of superior safety.
That's a real plot twist.
It is, and that's why this research is so pivotal. They dug into why. And the primary driver wasn't the robot's fine motor control or the platform itself.
So what was it?
It was the longer duration of intraoperative ventilation required for these robotic cases. When we do robotic surgery, patients are often in these steep head-down positions for a long time, plus prolonged pneumoperitoneum.
So it's the whole systemic setup required for the robot to even operate, not the robot's instruments, that's raising the risk of lung complications.
Precisely. This is pivotal, real-world evidence. It underscores that we can't just transplant old anesthetic protocols onto new platforms. It forces us to specifically optimize anesthetic and ventilatory management during robotic procedures.
The technology is only as safe as the systems around it.
That's the lesson.
Which leads perfectly into the work on defining global quality standards. If the platform needs new standardization, the procedure certainly does.
Yeah, and an international consortium did just that. They pooled data from high-volume expert centers to establish global benchmark standards for minimally invasive right hemiclectomy for cancer.
This is so essential for elevating the quality floor everywhere. Instead of just letting individual centers decide what's acceptable, they're analyzing what the top performers achieve globally.
Exactly. Defining target metrics for operative time, for complications, and most critically, for oncologic clearance.
It gives everyone, from major teaching hospitals to smaller programs, a concrete evidence-based target. It shifts quality improvement from an abstract goal to a measurable world-class metric.
And when institutions try to enforce these standards, they often turn to checklists. But the multi-center SmartCheck study gave us a really key, nuanced takeaway.
Right, this was for colorectal surgery, and they found it wasn't a simple yes or no on whether checklists work.
Precisely. The checklists alone, they only modestly improved operating room conditions. They reduced complications a little bit.
But not a game changer.
Not really. The significant improvement, the truly meaningful drop in serious issues like anastomotic leakage, only came with the implementation of the full care bundle.
And what did that include?
Critically, it included mandated feedback mechanisms and compliance monitoring.
So a static paper checklist is passive. It just sits there. But the full care bundle with that constant feedback loop that drives active cultural change in the OR.
That's the key takeaway. Standardizing care requires comprehensive, dynamic bundles, not just isolated, static safety lists.
Okay, now we move into segment 3, where the evidence gets cold, hard, and often challenges some deeply ingrained surgical habits. These head-to-head trials are often the most decisive in changing practice because they compare two established options directly.
And our first example here is huge. It's the BioLap randomized clinical trial. This was all about mesh choice in laparoscopic inguinal hernia repair.
A really robust trial. It compared expensive biological mesh versus just standard synthetic mesh in nearly 500 patients.
Right. And the hypothesis behind using biologics was, the hope that they might integrate more naturally, lead to less inflammation, less chronic pain.
Avoiding that whole foreign body reaction that people worry about with synthetic mesh.
Exactly. But the results were definitive. They were dramatic. At 6 months, pain scores were identical between the two groups. No difference in pain.
Okay, so no benefit there.
None. But the real difference was durability. At 2 years, hernia recurrence was dramatically unacceptably higher with biologic meshes 11.2% versus only 2.5% for synthetic.
Wow. That's not just statistically significant, that's clinically catastrophic for that patient.
It is. And they also saw more fluid collections, or seromas, given these materials are exponentially more expensive.
Is this finding going to be controversial for surgeons who adopted biologics hoping for an edge?
Absolutely. But this study reinforces that, in this setting, expensive biologic meshes offer no pain benefit and lead to significantly more recurrences. It basically settles the debate. Synthetic mesh remains the standard of care here.
We saw another assumption challenge, this time in advanced cancer surgery, with a non-inferiority trial for advanced T4A gastric cancer.
Right, comparing laparoscopic versus open distal gastrectomy.
And for you to understand the challenge here, you need to know that T4A means the tumor is locally advanced. It's penetrating the outer lining of the stomach.
And they compared it against the gold standard, a D2 lymphadenectomy, which is a very expensive, highly technical lymph node removal.
And historically, surgeons just defaulted to open surgery for these high-stage cancers. The fear was that laparoscopy couldn't provide that extensive clearance safely.
But the finding here was that short-term outcomes, so 90-day complications, and most importantly, the oncologic margins, they were statistically equivalent between the laparoscopic and the open groups.
That's a huge milestone. It suggests that in the hands of experienced high-volume surgeons, and that's a key caveat.
A very key caveat.
A minimally invasive surgery can safely treat even these advanced tumors.
And finally, in this segment, let's look at prehabilitation, optimizing patients before surgery. We have 2 key trials showing that efficacy really depends on the patient's baseline and how personalized the intervention is.
The first one focused on home-based rehab for frail older adults.
They proved it was highly feasible, which is a win in itself. Adherence was high. But the intervention did not significantly change the primary outcomes, like length of stay or major complications.
So for this most vulnerable group, just being feasible isn't enough.
It's not. They likely need something much more intensive, maybe medically supervised, or just a longer duration of preparation to see a real, measurable benefit.
But then we saw the trial comparing personalized versus standard prehabilitation.
Right. And in that one, the personalized group showed improved immune parameters and slightly better functional recovery.
So what's so promising there?
It's the focus on biomarkers. The personalized group was monitored and treated to optimize factors like their systemic inflammatory response. This suggests that tailoring pre-op prep by monitoring objective measures like immune status instead of just counting steps, that could be the key to better outcomes.
Our final segment now looks beyond the operating table. We're focusing on patient experience, systemic issues, and foundational knowledge.
Let's start with recovery and multimodal pain control. The RCT on intrathecal morphine is a perfect example of this.
Right, so intrathecal morphine is delivered directly into the spine for really potent pain relief. They showed that adding just a single low dose of it to a standard tap block, that's a regional block of the abdominal nerves, significantly improved pain control and recovery in laparoscopic colorectal surgery.
And this was highly praised because it accelerates recovery. It provides superior pain control right when the patient needs it most, which means earlier mobilization and less reliance on systemic opioids later. It's a very smart approach.
And moving to policy, we saw some crucial findings comparing postoperative outcomes in Medicare Advantage versus traditional Medicare beneficiaries after cancer surgery.
Yeah, and this data is vital for health policy experts. That highlights how subtle differences in insurance and care structures can translate into measurable differences in surgical outcomes.
And on the preventative side, we saw the power of simple low-cost interventions. A research letter highlighted nicotinamide, which is just vitamin B3. And it can reduce the incidence of non-melanoma skin cancer in high-risk organ transplant recipients. An incredibly simple, low-cost chemopreventative agent.
And underpinning all of this is the infrastructure data. We saw new guides for surgeon scientists on image-based, big data research, how to use large EHR datasets rigorously.
That's crucial. The quality of our future evidence depends on using those massive datasets correctly.
And we also saw new patient-reported outcome measures, or PROMs, specific to hernia surgery, reflecting that necessary shift toward value-based care where the patient's own experience is explicitly measured.
Finally, there was this wonderful reflective piece, a historical perspective examining the absence of jointed scissors in Greco-Roman surgery.
It's such a compelling look at the practical constraints of the past. I mean, imagine having to do complex surgery without the simple mechanical advantage of jointed scissors.
Relying on knives and scalpels?
And traction. By comparing those ancient constraints with our modern tools, you really appreciate how resource limits shaped early surgical practice.
Yeah.
It's a reminder that fundamental concepts like achieving wide exposure, they persist even as our tools change drastically.
So what does this all mean for you? We've seen this relentless push for extreme precision with tools like Rise-Desivan and predictive diagnostics like the CPG-EP test. We've seen the absolute necessity for rigorous standardization, whether it's setting global benchmarks or making sure we implement full safety bundles, not just checklists.
Yeah.
And maybe most importantly, we learned the importance of challenging assumptions. Recognizing that robotics needs optimized ventilation or that an expensive biologic mesh can be dramatically inferior.
The overarching trend here is hyper-personalization, and it's driven by deep molecular data. If we connect this back to those promising but subtle results from personalized prehabilitation focused on immune markers, it raises a really important question for you to consider. Given these subtle successes in modulating the body before surgery based on individual molecular status, how much more integrated will molecular diagnostics and, say, targeted preoperative immunotherapy become in routine surgical preparation 5 years from now?
A truly provocative thought. This analysis was based on the profound review by Dr. Reza Lankarani, editorial board member of the Genesis Journal of Surgery and Medicine. To access additional details and pioneering discussions, please refer to the Surgical Pioneering podcast series application at https://surgicalpioneer.codedax.me.
Thank you for joining us for this deep dive into the future of surgical science.